just to maybe introduce Almudena while we're waiting for her so we can save some time. Almudena, she is a consultant neonatologist working in Cadiz in Andalusia in Spain, and she has extensive experience in the use of lung ultrasound. She is leading the Spanish lung ultrasound team with a particular interest in the use of lung ultrasound in neonatal intensive care, but also for the assessment of the risk of developing chronic lung disease. So moving from the acute setting to the chronic setting, and she has done multiple studies in supporting the value of lung ultrasound in neonatology. Most recently, I would suggest to you, if you have time, to read this really elegant paper that she has recently published together with the ESPR Pulmonary Research Consortium, which is a paper that talks about the use of neonatal lung ultrasound in Europe. A survey that, again, highlights the importance of using lung ultrasound, but also how difficult it is to then actually be able to use that on every day in our units, simply because there's still a lacking of training resources and curriculum. But again, highlighting how we could really all benefit and how our patient would benefit from the use of lung ultrasound. Specifically today, she will be talking about the assessment of the neonatal diaphragm function. One of the tools that we know that we have in our toolbox is to use lung ultrasound to assess the readiness for extubation, which in some centers has been studied as a combination of lung ultrasound results combined with diaphragm function, again assessed by lung ultrasound. So we are hoping to learn something interesting, something new from Almudena, which I think has just managed to join us. And I will stop sharing and rambling. So then she should be able to just check out.
Hello, Anna. Hello, everybody.
Hey.
My deepest apologies.
No worries at all.
I thought it was at another time. Sorry. I was just eating assessment of diaphragm using ultrasound, in which there's different measurements that we could think of when we are using ultrasound in terms of evaluating diaphragm. We first will see a few slides about how to perform diaphragm ultrasound and different measurements that we can use for, and then just a revision on all the functional uses that we could apply this for. This is the first measurement and the most logical one when we think about how diaphragm is been functioning. The first thing that we should be aware of is the displacement of the diaphragm from upwards and downwards during the respiratory phase. In this first approach, we are looking at the diaphragm from a subcostal view at the level of the mid-clavicular line. And you will see this image here in which you're watching the liver, and using the liver as a window, as acoustic window, you can see this hyperechogenic line here, which is the diaphragm. You can use the M mode there to measure how the diaphragm is moving upwards and downwards through the respiratory cycle, as you can see here. This is called the diaphragm excursion, and we can measure it from the top of the hyperechogenic line till the end of it. This will be the inspiratory phase, and this is the expiratory phase, okay? We will see some examples, and this is the other measurement that we can do in this approach would be the slope of the inspiratory velocity of the diaphragm, which is another measurement that we can perform here to get an idea of how the diaphragm is how the diaphragm is moving, okay? This will be some examples of how to place the probe. As you see, we are using here a sectorial probe, but you can use the convex probe again as well, sorry. And this will be more or less the place in the mid-clavicular line, both in the right and the left sides, okay? But we have the luck that there are patients, the neonatal patients are very small, and we can also measure diaphragmatic excursion from also a subcostal approach, but just in a in a transfer view that you will see in the next slide, in which you can see this will be the liver, the stomach, the spleen, and this is the spine, and both posterior domes of the diaphragm are seen at the same time, and we can compare how both of them are moving just in the same image. This is a view that we can only use in very small patients, both neonates and infants, because the probe has to be big enough so as to be able to see both sides. This will be more or less the place to look at the probe. This will be a transversal view from a subcostal approach. And to understand what we are watching using these views, you have to take into account that in diaphragm excursion, we are seeing the diaphragm moving upwards and downwards through the respiratory cycle. This is an schema of the head of the patient and the diaphragm over the bed or the cot. And when we are using the ultrasound being from a subcostal approach, we are watching really the posterior dome of the diaphragm here. So in this view, we really are seeing an oblique view of the diaphragm, in which we are really not being able to measure how thick the diaphragm is, because we are really not getting an image which is completely perpendicular to that, to the dome of the diaphragm. And this is why we should use another views so to be able to measure it correctly. This schema is also useful for you to understand. Then when the diaphragm, when we inspire, the diaphragm would go down, and when we expire, the diaphragm goes up. However, in the image that I've shown you before in the ebb mode, you have seen that the inspiratory phase, the diaphragm is going up, and the expiratory phase, the diaphragm was going down. This is because when the diaphragm, let me put this again, when the diaphragm goes down, it goes towards the probe, and when it gets up in the expiratory phase, the diaphragm is moving away from the probe. And this is why in the M mode, you're really watching it moving in the opposite direction as you would think when you are when you think of the normal movement of the diaphragm. So this is another example. This is diaphragm excursion, okay? And here you can see some tips that maybe could be useful, in which it is the place when you, the place where you place the place when you locate the beam has also some relation to how we measure this movement of the diaphragm.
Sorry, Nuruddin, could you please switch off your microphone? Thank you so much.
Thank you.
Thank you.
In this image here, you are seeing that we have the M mode line just over the diaphragm, but this is in a bit also oblique. This is not completely perpendicular, and we are placing it in a place where the diaphragm almost is not moving at all. We should locate this more in this area where the posterior dome of the diaphragm is located. You can see here, this would be the movement that we are watching in this video of the diaphragm excursion, which is really quite soft, and it's not moving very much. If we see the same patient placing the probe in the correct position and using the ebb mode line more perpendicular to the diaphragm, you can see this very nice image here in which you can measure the excursion more correctly. This is another variable that we should rely on, that the sedation that we give to our patients is also influencing diaphragm excursion, as you can see here. This is the same view that we were reviewing in previous images, and you see how this diaphragm is moving more slowly, okay? You are really getting it more or less in the correct position, but the diaphragm is like a bit tired. It's going, it's not moving as fast as the images that we said before. And we could really take a look at that using ultrasound. You have some images here. This is the subcostal view from a subcostal approach from a transfer view, in which you are seeing both posterior dumps of the diaphragm moving more slowly due to sedation of the patient. And this is the most extreme situation in which the diaphragm is almost not moving at all. You almost don't see the excursion of the diaphragm in any of both sides in a patient which had a completely sedated and intubated with very low respiratory settings, though the diaphragm is really moving quite low, okay? And after this, that we've been reviewing about diaphragm excursion, you have to rely on that, as we were saying, the respiratory support that we are giving to a patient is also influencing these measurements. This baby here is a baby who had brain damage, a severe brain damage, and he was already in brain death, but he was still intubated, waiting for donation. And as you can see here, if we perform just this subcostal approach, we really are watching a diaphragm which seems to be moving, although the patient was already dead. And this is why, mainly from adult critical care settings, we began to use another views to evaluate how the diaphragm is moving. From a lateral approach here, this area here, which is called the zone of apposition, it's a place where the diaphragm is almost completely parallel to the chest wall, and we are really watching the diaphragm really very near from the probe. So we are able to see exactly how the diaphragm is getting thicker and thinner throughout the respiratory cycles. Here you can see the diaphragm in one phase, and this is when the diaphragm gets lower in the inspiratory phase. So evaluating the diaphragm from this position here may make you some more idea of how the diaphragm is functioning, just measuring the thickness in both phases. This will be some views of where you should place the probe to evaluate this zonus apposition in the 8th to 19th intercostal space here, okay? In this case, we are using a linear approach, a linear probe, because we are really very near to the diaphragm, and we want to see, we want to use the probe with the highest frequency that we may have. In this schema here, you can see the difference in which we are using this lateral approach here in the zone of apposition. This will be the image that we would see. This is the lung, the ribs, and there's just one space in which we stop watching the lung and begin seeing these two parallel lines here with this structure between them. These two parallel and hyperechogenic lines would be parietal pleura and parietal peritoneum, and between them, this image here will be the diaphragm. We can measure this diaphragm just. You can measure this diaphragm, how it's get thicker and thinner. It is getting thicker and thinner in the inspiratory and expiratory phases, okay? We'll see better in the next slide, if I can change the pointer. Okay, in this image here, we have already measured using the M mode how the diaphragm is getting during the inspiratory and expiratory phases. Okay, this is more or less the same image as you've seen before. We have here the liver, and these two parallel hyperechogenic lines would be those that are really involving surrounding the diaphragm. And in this case, we have to measure, just not taking into account the two parallel lines that we have seen in the video. As you can see here, the dots are placed just inside those lines, both in expiratory and inspiratory phases. The correct measurement will be performed like this, in which the inspiratory phase is taken into account with the previous expiratory phase, not the next one. If we take these measurements, you can also calculate another new variable, which is diaphragm thickening fraction, which resembles the thickening fraction of the heart that we can also you can also calculate to measure the function of the left ventricle, in which we use the inspiratory thickness minus expiratory thickness divided by the expiratory thickness. This is a value that's calculated with a percentage of the whole expiratory thickness. Okay. In this image here, this distance A would be the inspiratory thickness of the diaphragm in this patient, and this distance B would be the expiratory thickness. So we have this patient with a brain death, which has a normal excursion. If we, because the patient is intubated, if we only evaluate the excursion, we could say that this diaphragm is moving, but really is the ventilator itself the one that's moving the diaphragm. When we evaluate the zone of apposition here, you can see here two ribs and these parallel lines here, which are surrounding the diaphragm. You can see in the ebb mode how the diaphragm is completely the same. This it's not really changing its thickness during the completely respiratory cycle, because it's not really moving at all. So using these two approaches, we can more or less rely on how the diaphragm is functioning in different patients. This is some examples of what we can measure both in the right and the left side. You have to take into account that the best location to measure the diaphragm thickness and the excursion is always the right side, as you can understand, because in the left side we sometimes have some, we don't have the best acoustic window that the lever can give us to measure these movements. Sometimes it's important to measure both sides, but if it's not, when you're not expecting a new unilateral paralysis, then you should really take your measurements only in the right side. This is the same patient with the measurement performed in the right side, and in the left side, you can see that we have the stomach here with some air, liquids, and so on. And you can see how the measurements not perform as well as we are able to do it in the other side. And this will be like the worst situation. This is a patient with an eventration, a diaphragm eventration, in which we are really watching the diaphragm really, really, really thin. We almost are not able to see differences between the peritoneum and the pleura. We are not really watching a diaphragm more than just 0.1 millimeter thick, and it's also located very high in the sixth intercostal space. In this case, diaphragm thickness and diaphragm thickness fraction is also influenced by sedation. This case here was a patient that was going to be intubated and sedated for surgery. You can see here normal thickness of the diaphragm in inspiratory and expiratory phases. During sedation, you can see that the diaphragm is almost moving very slow and really is not changing the thickness more than just very few millimeters, and you can see the difference in how the diaphragm is moving after sedation and after the baby was extubated. So after all these images and some tips on how to do it, I just wanted to talk a little bit about some things that we can use the diaphragm for. This is mostly influenced by adults' bibliography, you would see. And maybe we can think that this is something quite useful, but maybe I think, in my opinion, it's not that useful, and it is in adult critical care patients. We will have a few words about intercellular agreement of these measurements. This study was performed in adults ICU, in which the authors compare both diaphragm thickness in expiratory and inspiratory phases and thickness fraction of the diaphragm. You can see that the thickness of the diaphragm has very high, both repetitivity and reproducibility measurements, but the both coefficients are quite lower when we take into account thickness of the diaphragm. You have to realize then when you are measuring something, there's just 1 or 2 millimeters thick. Small difference can have very high differences in terms of intercellular agreement. And this is something in adult patients. Imagine in neonates or in preterm infants, where the thickness of the diaphragm is much lower. This is for the whole sample. And I also wanted to take into account the fact of the sides of the diaphragm that we were saying before. Here, as you can see, there are bigger differences and lower intercellular agreement in this study when the authors compare the right and the left sides of the diaphragm, with always with higher repetitivity coefficients when they use the right diaphragm. This is a study that we performed a few years ago in our unit, taking into account these measurements, mostly in terms of thickness of the diaphragm, not just excursion, in which we evaluated neonates and premature infants without respiratory distress. And we tried to measure intercellular agreement between an expert examiner and different novice users, like other neonatologists or residents. As you can see here, this is the Blanc-Almond agreement graph, in which you can see that the difference in the measurements can range from 0 until more than 20%. So this is something that you have to be really confident with your measurements before you can use it in a clinical or in a research setting, because it can be really difficult to reproduce in our population. But what are the normal values? In terms of excursion, this classical paper published by a radiologist group, published in 1994, said that the normal excursion of the diaphragm in neonates is 4 millimeters. But we also have to take into account that the transition between the inspiratory and expiratory phases have to be sharp, and the diaphragm movement has to be down in inspiration and up in expiration, which is what I explained before. Sometimes you can see some difference between size that has to be less than 50%, but you have to. This is the reference where most papers get these values of normal values from, but you have to take into account that this was just analyzed in 7 patients, so it's something that is important as well. What about diaphragm dimensions in different preterm infants, not just term infants? As you can see here, both inspiratory thickness of the diaphragm and changes of the thickness of the diaphragm in an excursion said that the most premature the baby is, the higher diaphragm excursion that they have. Okay, so you can see here, the excursion is being reduced when the baby is premature and gets to normal values of term infants when the infant's almost a term infant in postmenstrual age. So it's like, just as the baby's more premature, they need to have more displacement of the diaphragm to get a normal respiratory situation. In this paper that we published 2020, we also get some information about thickness of the diaphragm in terms of premature infants. You can see that they have different inspiratory and expiratory measurements, as you can imagine. The older the patient is, the thicker the diaphragm is, both in inspiratory and expiratory phases. And they were all babies with respiratory distress. But as the shortening fraction of the diaphragm or thickening fraction is a quotient between the two measurements, this value remains more or less stable, both in terms of premature infants. This is another paper by a group from the north of Europe, in which they got different infants from 0 to 8 years. And this is the neonatal group that included 28 patients. And you can see how the thickness of the diaphragm and the quotient of both measurements are more or less similar. In this paper that we published last year, I think, included more than 100 patients less than 32 weeks gestational age at birth, and we measure inspiratory and expiratory phase thickness of the diaphragm in the first day of life, then at 3 days, and then weekly until discharge or getting 36 weeks postmenstrual age. And we got how this both inspiratory and expiratory thickness in both sides increase progressively since birth, irrespective of the need of mechanical ventilation that they had, both in infants born before with less than 1,000 grams and more than 1,000 grams at birth. This is however, this is the both right and left thickening fraction. We use thickening and shortening fraction interchangeably. You can see how they, however, remain relatively constant from birth until discharge. So this is something to also rely on. And what variables can influence these measurements? Well, the first one could be, or we could think of, is the amount of calories that we give to our patients. In this paper published in 2001, this group from the USA demonstrated that the thickness of the diaphragm is not related to the amount of calories that we give them. Okay, so yes, this is a muscle, but the movement that this has, this is thickness, is not that related to the neutral intake. I imagine that even though that this is all performing infants who were not undernutrited at all. However, the position of the babies does influence these measurements. These were diaphragmatic thickness of the diaphragm, and this is at expiratory and inspiratory phases. And you can see how the supine and prone position has different measurements that has to be taken into account when we are performing an exam. Always in the supine position, the measurement seems to be lower than in prone position. Some other measurements that also influence diaphragm thickness are, of course, the level of respiratory support that we give to our patients. In this study, the same group of premature infants received different levels of CPAP. And as you can see, both inspiratory and expiratory thickness of the diaphragm changed when the babies received more levels of TPAP, higher levels of TPAP. They have higher inspiratory and expiratory thicknesses. And we begin with some functional uses, which is the first one, and I think the most important in our population, is the diagnosis of diaphragm paralysis or diaphragm eventration. The paralysis of the diaphragm is something that's iatrogenic, mainly related to obstetric trauma, surgery, and so on, and is most cases it is symptomatic and it's more frequent. But we sometimes have to face with diaphragmatic eventration, which are congenital diseases related to neuromuscular disorders or lung hypoplasia, for example, but are mainly asymptomatic. In this classical paper that I've shown before, you can see some other characteristics of the diaphragm paralysis. that the direction of motion is the opposite as in the normal one. In this case, the diaphragm moves upwards in the expiratory phase and downwards because it's the other diaphragm, the one that's moving the ill diaphragm, the ill dome. And the transition between the inspiratory and expiratory phases is smooth. It's not sharp as in the normal diaphragm. It's really slower. The excursion value could be variable, could be normal values as well, but the normal movement of the diaphragm is different. In this case, you have to rely more on the slope or the inspiratory velocity of the diaphragm to really make a difference. Here you can see an example of a baby with a diaphragm paralysis in which you can see that the excursion is not within the normal values, but the transition between the inspiratory and expiratory phases is really smooth. It's not that sharp as we were seeing in the first images. Some other examples here that I've shown before in which we have this smooth transition between one phase and the other in the respiratory cycle. This other baby with a diaphragmatic eventration in which you can see the normal diaphragm in the 9th intercostal space, which has normal thickness. The diaphragm's moving and it's getting thicker and thinner through the inspiratory and expiratory phases. And this other is really not moving at all, doesn't change its size, and it's really higher in the thoracic wall. Another example of a baby with a diaphragmatic eventration that you can see here in the X-ray. You see that the diaphragm, the healthy diaphragm is really getting with hard growth of breathing. It's moving too fast and it's getting much thicker than the normal images that we've seen before. However, the diaphragm that's eventrated, it's really not changing its size and it's really not moving at all. What can we do in terms of analyzing diaphragm function to predict extubation failure? These are data from an adult ICU settings in which this group of others, this is the last meta-analysis published in this issue in 2023. And the authors evaluated both the excursion and the thickness of the diaphragm in all papers previously published. And you can see that the first one has area under the curve around 0.8 to predict extubation failure, and 0.9 using thickness of the diaphragm to predict extubation failure in this population. And what are the data in neonatal ICU patients? This is the first study published 4 years ago, in which this group of others evaluated different preterm infants before an extubation attempt, and they compared those with successful extubation and failed extubation that you may see here. They got significant differences in terms of excursion of the right diaphragm and the thickness of the diaphragm in all patients evaluated. But when we review the images of that the others provide in their manuscript, you see that both the excursion of the thickness of the diaphragm has been evaluated from a subcostal approach in which we said that's not the correct position. In this way here, we are not really evaluating the diaphragm from perpendicular view. So this is not correct to evaluate the thickness of the diaphragm, not even the inspiratory, neither expiratory thickness. And this other paper published in 2023 by a Canadian group included more or less the same number of patients, but more premature. They were all less than 28 weeks of gestation. And they also divided them in terms of successful and failure extubation attempt. And they evaluated both lung ultrasound score at the moment of the attempt and excursion, inspiratory, expiratory thickness, and thickness fraction. As you can see here, the only variable related to the extubation failure is really lung ultrasound score and not the diaphragmatic measurements. And this is it. I mean, we have no more references in neonatal population about the use of diaphragmatic measurements to predict extubation failure. And another function for this evaluation of the ultrasound units is to evaluate the function of the diaphragm in patients with critical care diseases. This is something that has been recently described in adult population, in which different factors like the need of invasive mechanical ventilation, some medications like corticosteroids, sepsis, malnutrition, so on, can begin a cascade of inflammation and mitochondrial oxidative stress that at the end is related to muscle atrophy and contractile dysfunction. So this is the concept of ventilatory-induced diaphragmatic dysfunction that has been also studied in animal patients, in which you can see these are the muscle fibers of animal models in which the control ones are completely different than those with critical illnesses, and also in the number of fibers that they have. There's also different publications about some medication that are related to diaphragm dysfunction, which are, for example, propofol or midazolam, but not dexmedetomidine, for example. So also sedation is related to diaphragm dysfunction. We know from adult publications that when the patient has this decrease of thickness of the diaphragm, this diaphragm atrophy or diaphragm dysfunction measured by lung ultrasound, it is related, both the decrease and the increase is related to longer duration of invasive mechanical ventilation and longer ICU admission, duration of hospitalization, complications, reintubation, tracheostomy, or the need of invasive mechanical ventilation for more than 14 days. So this is something that's quite important. We also have some animal studies that relate diaphragm dysfunction to more prolonged need of invasive mechanical ventilation in neoborn animal models, as you can see here. This is a study in which the authors use lambs with mechanical ventilation and without, the blue line here. And you can see that the force that the diaphragm is able to produce is different in control animals than those that need invasive mechanical ventilation. But the only publications that we have in neonates, in this case, extremely preterm infants, are just two again. This was published in January last year. This is a Japanese group that included 20 preterm infants born before 28 weeks that needed invasive mechanical ventilation in the first 6 hours of life. And you can see here how both the inspiratory thickness and thickening fraction decrease after the intubation from the first day to the second day of life, and continue to decrease afterwards, although the difference was just statistically significant between day 0 and day 1. However, in this paper, the others don't describe if the babies received sedation for this procedure. And we could say that this is due to a diaphragm dysfunction, or maybe the diaphragm is like more relaxed now that the using invasive mechanical ventilation with the ventilator, the work of breathing has been reduced. We don't know it yet. This paper published this year, a few months ago, they included 17 patients, and they defined the existence of a diaphragmatic atrophy when there was a decrease in expiratory thickness more than 20%. And they compare diaphragm measurements before and after the intubation. They found diaphragmatic atrophy in half of the patients from this sample. And this diaphragm atrophy was more frequent in those patients that had an extubation failure. However, when they combined more variables in a multivariable analysis plan, they had that this diaphragmatic atrophy was not related to the extubation failure. So as you can see, there are just very few references in this field, so as to be able to say that in neonates and mainly in preterm infants, the invasive mechanical ventilation is related to diaphragmatic dysfunction. We come to this other paper that we published last year. that included more than 100 babies, preterm infants, since birth. And we also measure both excursion, inspiratory and expiratory fractions, and evaluated using multi-level regression analysis what variables were related to the changes in size of diaphragmatic measurements in this population. And as you can see here, in the multi-variable analysis, the only variable that's really related to this change in diaphragm function or the growing of the thickness of the diaphragm is the birth weight of the babies, not the days of invasive mechanical ventilation, neither the final diagnosis of BPD, on-lateral sepsis, and so on. No, not even in the right and the left inspiratory and expiratory thicknesses. So in this paper, we're just kind of describing how thickness of the diaphragm is changing through the time, and that maybe these other variables are not really important in this change of size. Just a few words about studies of diaphragmatic function using ultrasound and some specific pathologies in neonates. This one from a Canadian group by Dr. Mohammed. They evaluated more than 100 infants, half of them with BPD and half of them were healthy term infants admitted in the unit for different conditions. And they compare both thickness, expiratory thickness, inspiratory thickness, both absolute values and related to the body surface area, and as well as expiratory thickness of the diaphragm fraction, sorry. You can see that when the authors evaluated expiratory and inspiratory thickness related to the body area, they found significant differences between the BPD and term infants, as well as thickness and excursion of the diaphragm. As the BPD patients have higher work of breathing, they have higher thickness fraction and higher excursions compared to term infants with the same age. And this last paper was published by a group from UK and the group from Greener, that they evaluated different patients with and without BPD, and sorry, without PDA, and they evaluated how the diaphragm was moving in terms of excursion and inspiratory velocity, because there are some publications in adults settings that patients with left ventricle dysfunction have slower movement and dysfunction related of the diaphragm. As you can see here, they found significant differences in terms of excursion and inspiratory velocities as well, but there were also significant difference in the gestational age of the patients included, which we have seen that's something related to these measurements. And just to zoom with, we have to rely that this measurements of diaphragm functioning are difficult to perform, but it can be used in case of expert hands. It could have high reproducibility, but mainly in pre-recorded images. The assessment is better when we use the right side. The normal values of the infants are different according to birth weight and gestational age of the patients. These measurements are influenced by the respiratory support and the position of the babies, but we still have doubts that it could be useful for extubation failure or diaphragmatic dysfunction in neonates of invasive mechanical ventilation. And the patients with BPD have different values compared to their term counterparts. Thank you very much for your attention. And again, sorry for this beginning of the talk. And I'm open for all your questions, if there's any.
Thank you, Molina. Fantastic presentation as usual. I think you're spoiling us. I will just ask Tom John to mute his microphone unless John has any questions. Thomas, John, do you have any question for us, or do you want to mute your microphone? Anyway, fantastic presentation, and I'm always incredibly envious of your images. I think we have all learned a lot from today's talk. One of the things that I'm wondering is how are you using that in your unit now? Because we have seen many studies that you have presented to us, some observational studies, but there's still some conflict information about the actual clinical use of the assessment of the diaphragm movement. How do you find it useful when you translate that into clinical practice for now?
Well, nowadays, I think the most important use diaphragm ultrasound is just to diagnose diaphragmatic paralysis. I don't know if you understand well. Just for diagnosing diaphragmatic paralysis, because this is it's a measurement that's difficult to perform. It's difficult to really have high interobserver agreement. So to use it in clinical practice, we have to really have more detail and data on the clinical usefulness of these measurements, I think. I think we have to pay more attention to the diaphragm to monitor our patients, but maybe diaphragm ultrasound, it's not the best way to do it, at least with the beams and the ultrasound machines that we have nowadays.
I understand. And I guess one way to kind of assess if this will become a useful tool or not is to, in the meantime, build enough confidence in assessing the diaphragm. You were talking about the interpersonal variability in assessing it. How easy do you think it is to learn how to perform this procedure? Is it something that's taken a long time? How do you see that as part of a training program?
This is not an easy measurement. In Spain, we have, in our National Society of Neonatology, we have a focus lung ultrasound course, and we don't really teach the students how to perform these measurements, because this is something to be performed when the examiner has a high level of proficiency using focus or ultrasound as well. So this is not something easy to learn. You need to have a very long learning curve to really rely on your measurements. So I have to have a clinical implementation in your unit.
Remains the same concept, okay? Depending on structure.
I'm going to ask again Thomas John to mute himself, because I can't kick him out of the meeting, unfortunately. If anybody knows Thomas John in person and want to text him, that would be fantastic. Just wonder if anybody else has any other question. Otherwise, I have many, but I don't want to take over the whole meeting. Yeah, Vikash.
Hi, Almudena. Thank you so much for such a fantastic talk. And though I've heard this talk, diaphragmatic talk from you before, but every time I hear, I learn new things. So as Anna, my colleague, mentioned, is the limitation of the use. And every time I put my probes, I try and do the diaphragmatic movement. I do the thickening index and also the excursion, and just to get my skills, though I don't know how to interpret them that well. And that's why when last meeting we were discussing with, I was not very much comfortable with the normative values. So my question is just as I'm having my learning curve, for people like us, what is the right? So I generally have two views which I try and obtain. One is the normal cardiac probe I use, and as a subcostal, I trace the border of the diaphragm, and I do an M mode there, which helps me to give the excursion. And then I do the thickening index. I generally use the lung probe, the high frequency probe, and I generally do it at the level of L2 or the lower border, where I can see the liver as well as the lower parts of the diaphragm muscles coming in. And that's where I do the thickening index. Is that the right way?
Yes, perfect. That's correct. one limitation of this measurement is that I don't really know the reason why, but mostly when you're evaluating thickness of the diaphragm, you can find very different measurements from one mama to another in the same patient. So this is, maybe you are doing it correctly, but maybe you have different images just because the patient is breathing faster, or it's getting annoyed by your exam, or maybe it's sleepy or whatever. And this is something that reduces the functional uses of diaphragmatic ultrasound.
So even at the serial measurement, the thickening index will change, right? Because depending on the child's state, whether he's happy, unhappy,
Yes.
and so the diaphragm function is changing. I mean, because thickening index is a good marker for diaphragmatic functions.
Yes, I think that the gut diagnostic accuracy that these measurements have in adults patient is not the same as in our population, I'm afraid.
Yeah, but we can see that whenever we go and teach in the courses. I remember last time teaching on one of our colleagues, Ahmed's son, and I could show the diaphragmatic, when we did M mode, you can see the diaphragm is very much like the TAPC. You can see that so well. It's a huge difference. So I think the room for errors are much more lesser than when we do it in our tiny preterm babies, where you'd hardly see any movements. And sometimes you feel that it's an artifact issue, actually.
Yes, I completely agree with you, Bikash.
No, thank you. Thank you, Almudena.
Thank you, Bikash. I think Mona has raised his hand as well.
Thanks, Almudena, for this fantastic presentation. I have a couple of questions. One of them is just about technicality. When you assess the diaphragmatic excursion, which probe do you use? Do you still use the linear probe, or do you use a curvilinear one?
Both curvilinear, both cardiac and abdomen probe will be ideal, whichever you have or you're more confident with.
So because I know we use for lung ultrasound, we use the linear probe, but for the excursion, as far as I know, it should be curvilinear. Can we do both with the linear probe?
You can try, but you have to increase the depth of your measurements when you're evaluating excursion, because as you've seen in one of the first slides, you have to look at the posterior dome of the diaphragm. And sometimes the linear probe, even if it's a very high frequency probe, won't be able to see in such depth needed to see the posterior dome.
Okay, so we can use either curvilinear or use the sectoral array for the any one we use for echo as well. It doesn't mean to be curvilinear.
No, I mean, you have to use one with low frequency, one being with low frequency. It doesn't matter if you use the cardiac or the convex probe. Okay, so the other question is for assessment for readiness for extubation. Do you put the ventilator on hold, or you can assess it well? Because if I think about it, actually the ventilator is breathing for the baby. If I assess this doesn't reflect what is the accurate state of the baby, or what is the correct diaphragmatic excursion, or the measurement. Do you hold? Do you stop the ventilator briefly and assess, or what do you do it? How do you do it? Yeah, that's a very important question. I really didn't pay much attention to this in the talk. When we have a baby ventilated, the excursion, as I said, is due to the ventilator. So as you are saying, if you aim to extubate the baby and you're watching the excursion, you have to reduce the amount of support the ventilator is given. You can change the baby to a pressor support mode or to a CPAP mode to see really the the diaphragm movement itself, not to the ventilator. That's a very important question and point.
Thank you very much.
Any other question from the floor? Can I just ask a brief one, Almudena? One of the study you were showing us is the changes in thickness based on different level of CPAP. I must admit, in my mind, I would have thought that if a patient is on a higher level of CPAP, is receiving more support, and therefore the diaphragm doesn't have to work that much. So shouldn't have that changes in thickness. But actually the study was showing the opposite result. How would you interpret that?
I don't know. That's an old study. There's another one published by the same group in infants, and the results are the same. It's like the diaphragm is reacting to the amount of pressure he's receiving, and it's getting thicker. But I don't know the reason why. I would expect, as well as you, that the diaphragm would get thinner, because it's receiving much pressure, it's getting lower. But I wouldn't say an explanation for that.
Okay. So it looks like we still have a lot to learn from the assessment of diaphragm. It might be that language ultrasound is just one of the methods and elements in assessing diaphragm function that might not be enough in isolation to then have a direct clinical application, at least in our, as we were saying, in our specific subpopulation of newborns, term and preterm newborns. Yes. Fantastic. Okay. Perfect. So if there are no other questions, I'm just double checking in the chat, sorry. No other questions that I can see. I'm just scrolling through, apologies.
Yeah, Barney is asking about studies with NEVA. There's one study in adult patients comparing diaphragmatic measurements using ultrasound and electrical activity of the diaphragm using NEVA, and this correlation is not as big as we may think. But this is something that has only been studied in adults and not in neonates, neither children. So we have much more to learn from that side as well. We are actually performing one study in our unit, which I don't have the results yet, but I can advance that the results are more or less similar. It's I think there are complementary measurements in monitoring the diaphragm. One thing is the electrical activity, and the other thing is the amount of movement that you get from the diaphragm using this electrical activity. So both measurements are not really highly correlated, I would say.
That's super interesting. Thank you so much for highlighting this aspect as well. Okay, so it looks like we have reached the, there's another question. No, just a lot of messages saying thank you and for the presentation. And I was just mentioning to the group that we then usually upload the recording of these lectures on our YouTube website, so it will be possible for others to then listen to the recording and learn from Almudena. So fantastic again. Thank you again for finding the time to join us today. We always appreciate your presence and your expertise when you share that with us. We are so grateful for that.
Thank you, Anna. And thank you for inviting me again.
No worries. See you soon then.
Bye.
Have a good day, everybody. Enjoy the weekend.
Bye. Thank you.